I hope you're all having a wonderful time with it. Aubrey founded SENS Research Foundation with me and a handful of colleagues a few years ago, but this conference predates us by a number of years. So we're only part of the history of this conference and its overall effort. Since the last conference, SRF has grown considerably. Our research budget is now, our total budget is now about $5 million a year. Our message has improved. We've expanded outreach and education activities, which you can read about online. That complements our much expanded research work. I invite you to download our just released research report. And we've rebranded under this Reimagine Aging tagline. But the big idea has always been about reimagining how aging was treated worldwide. So what I want to do right now is touch briefly on a couple points about what that might take and what we're doing to help it along. First of all, a little recap. I know most of you have heard this a dozen times. I know you all know this, but I do want to stop and do a 2-minute drill on what our mission is. SENS Research Foundation exists because we want to comprehensively prevent age-related disease from occurring rather than dealing with them pathology by pathology. So when we say reimagine aging, what we mean is this. There are two ways traditionally of looking at the aging process. Either you try to understand and control the metabolic processes, or you try to understand and manage the diseases that result from it. The study of metabolism in aging would be roughly the gerontological side of the equation. It's delivered great insight, but it's complex, it's little understood, and in fact we haven't even completed the map. On the other side, the study of the diseases of aging, roughly the geriatric side of the equation. It's also made great advances. Of course, both of my parents are alive today because of advances in oncology that have only occurred over the last 20 years or so. But the chase of these pathologies is complex too, and it's frustrating. And of the hundreds that you're seeing coming up there, we've retired none of them. We've eradicated not one yet. So the one change we push for at SRF is to get more researchers to look between metabolism and pathology arenas and to recognize that there are distinct types of damage that are occurring in all of us just as a normal part of being alive. And if you let them accrue unremitted for long enough, you're going to get all of the diseases of aging, and that's all there is to it. Look at the damage. Aubrey's proposal that he introduced some 13 years ago posited 7 types of damage. SRF puts a significant amount of research into checking periodically that that's the right number. But others have suggested 4 categories. Maria Blasco and other prominent authors just released a Cell paper. It suggests 9 categories. I suppose we'll eventually have to come to agreement on that, but for the moment the world can categorize it any way it wants. We just want them to recognize that for every age-related disease and condition, we can identify basic underlying pegs of damage that will accrue and eventually cause that disease. And that's how we're going to be able to teach ourselves to correct, to repair or remove the damage, and prevent rather than treat the disease. Aubrey was the first to make the analogy between that and the maintenance of your car. Change your oil and replace the piston rings, and then you don't have to pull the engine out. But I like it when we make the comparison to airplane maintenance. Because it suggests the regulatory change that I think we're going to need for this change to really occur. By about the time this clipper was flying over San Francisco, the regulatory authorities were already starting to realize that really safe air travel didn't mean waiting for the wings to fall off or the engine to fail. You had to have a preventative maintenance schedule for these things in the sky, and we couldn't wait around for them to have something go wrong before we did something about it. And it's worked enormously well. Casualty rates for aircraft travel year by year are approximately the same as they were when these things were flying now, even though every decade we get exponential growth in the number of travelers. Conversely, today we are in danger of collapsing under the economic weight of the management of chronic disease. By any measure, they are the world's greatest remaining health problems. They absorb an increasing amount of GDP in the developed countries, and they're emerging as the developing world's biggest problems as well. I believe cardiovascular disease just hit #1 in the developing world. If you have any doubt about the economic burden represented here, then pick up the book by Alex, The Ageless Generation, in your pack, and start reading from about page 135, and then come on back in. This graph shows the difference between the beginning of the last century and the end of it with respect to disease burden. And two things are relevant in this graph. First, we got really good at battling infectious disease. And second, even though we had enormous progress in the field, we didn't get very good at all at eradicating any of the age-related disease, nor even in reducing the economic burden of them. So what happened with infectious disease that hasn't happened with chronic disease? Well, it's very simple. We moved to a culture of prevention. We put energy and resources into attacking the diseases before they hit, and we were very successful. And now, in all but the most intractable of cases, we have reduced, and in some cases retired, the burden of the associated disease permanently. Our foundation budget this year is about $5 million. Most of that goes into research. To compare that with what goes on in the United States, inside of the Division of Biology of Aging in the NIA, they spend, we think, about $10 million on this kind of translational work. It's hard to measure because nobody really measures this. That's cut from a $160 million budget for that division, which is cut from that $1 billion budget for that institute. That's cut from the $30 billion for the NIH. And that itself is just a drop of the $1.2 trillion we'll be spending just in the US on healthcare for seniors just this year. There's an ocean of healthcare costs out there for seniors, and we're putting a tiny, tiny drop into prevention. So how do we change that? Well, I want to go back to that airplane again and look at it in context. This is flying over the San Francisco Bay while the Golden Gate is under construction. That's a photo that's framed in my office, and I asked for it to be put there as a reminder of what you all in the biotech industry would call the valley of death, the chasm between innovation and availability, and a reminder that we might be able to build the bridge of opportunity.
It's an old photo.
But for the preventative measures we propose, the chasm is a bit more daunting. On the one side, while there is building credibility for the concept of researching the damage precursors to disease, this is from us, this is from papers like Dr. Blasco's, this is from the great work of the GSIG that James was talking about. There's simply not enough credibility right now for the biotech industry to take over and make interventions that really do something about it. And on the other side, there is very little in the way of regulatory models and business models for drugs or other interventions that would treat damage that is a precursor to disease rather than disease itself. There are some blood cholesterol markers that are predictive of heart disease and associated drugs to manage that, but there's really not a lot else in that arena. So to build that industry, we use most of our resources to build credibility for the research. Quite a few of the talks you've heard or will hear are projects that are sponsored by us. We have a dozen significant programs, and they run the range from basic sciences in the MITO program to applied sciences, as you heard from Gazelle and Jacques, moving towards, we hope, clinical progress on these LISO programs. We make infrastructure tools like the genetically modifiable mouse you can read about online, and we do regulatory analyses. This is all by far the most important part of this organization, but I'm not going to review them in this talk, and that's because there are a dozen talks in this conference that talk about just those things. I just want to point out two of them, though, and that's Gazelle's seminar on the bisretinoid that causes macular degeneration, and Jacques' work on the nasty 7-ketocholesterol that causes athero. These are two programs that show we can do more than just basic research. We have applied programs that can move into the clinic, and we hope soon. Jacques' work's already demonstrated that we can protect cells from the 7-KC toxicity, and Gazelle and team sends 20 candidates, maybe ready to move into animal models against A2E now. I mention these because they can provide a model for interventions that can be labeled for a disease, but that will actually act on the earlier stage damage rather than the late stage disease. And we're going to come back to that in a bit. A bit of a secondary agenda with our research budget is to build further credibility by associating with organizations at the top end of the gerontological and regenerative medicine scale, organizations like the Buck Institute, organizations like the Wake Forest Institute in regenerative medicine, to maximize the areas where our interests will intersect with them. Just as an example, John Jackson told you about the thymus program. We helped Wake Forest get excited about the possibility of using their considerable talent in organ engineering to look at revitalizing the aging thymus and thus revitalizing aging immune systems. Aubrey supplemented that by asking world leaders in gerontology, geriatrics, and genetics to sign on to a statement of principles regarding bringing regenerative medicine to aging. That's grown to a research advisory board of 25 members, including most recently Dr. George Church, our keynote this week. And we also give a lot more attention now to making all this science accessible to the public at large. What you see running here are videos we commissioned from a group called Cosmos. These will provide us narrated examples of each of the seven types of damage and potential ways we might intervene with them. We can use this on our website, we can use it in presentations, here it is. But more importantly, these kinds of programs will allow us to have tools that we can share with science shows, with disease-based organizations, with other conferences and the like. Imaginative retellings of the aging problem that might give us more traction outside of the scientific community. I want to play just one of these for you. It's about 90 seconds long. It's a summary of Jacques' work, animated by Cosmos, narrated by the actor Edward James Olmos, and designed to explain what he's doing to a broad lay community.
We need cholesterol. All cells require it to function, and it's delivered to our cells via specialized particles in our blood. But sometimes these particles become trapped in the lining of our blood vessels. White blood cells, called macrophages, clear their stuck particles by absorbing them and processing them in compartments called lysosomes. Here, the particles are broken down into their constituent parts for reclamation or disposal. Once the enzymes have done their work, the reclaimed cholesterol is returned to the blood. The problem is, some cholesterol becomes oxidized during its travels. Oxidized cholesterol is poorly processed by the macrophages and eventually overwhelms them, preventing them from even processing the normal cholesterol they absorb. These sick, bloated cells are called foam cells, and they attract other macrophages, but the newcomers suffer the same fate. As foam cells accumulate, they form arterial plaques, which become inflamed and burst, spewing out blood clots that trigger heart attacks and strokes. But what if we gave the macrophages a new enzyme so that they could process oxidized cholesterol too? Then they would process stuck particles without getting poisoned and bloated and return to healthy function. This would progressively cleanse arteries of plaque that had already formed.
Again, the only problem with that video for me is I want to stretch out that end where the artery starts to repair itself, because Jacques, I got to tell you, that's the piece where you go, I want this technology available right now.
Yep.
If you heard Greg Chen, we're pretty aggressive about building relationships with students in educational institutions. We have a set of 10 online courses available with lectures from our RAB. We're working on a next generation set, and I'm very much hoping that this signals the start of an education agenda. We could move from here to college credit coursework, and I'd like to see us help educational institutions develop their own coursework, maybe even degree programs. What we'd very much like to do is convince students that they can be rejuvenation biotechnologists, for instance, lysosomal storage specialists rather than cardiologists, mitochondrial dysfunction specialists rather than disease specialists, maybe. And if that means helping support some kind of PhD program in rejuvenation biotechnology as itself someday, well, we could possibly go there too. Back at SENS 4, a student by the name of Kelsey Moody proposed that we began an intern program. That grew into a test program with Daniel Kimball, and now Greg Chin has the involvement of 6 universities worldwide and significant plans for growth next year if he can get the budget. The successful intern program helped us develop relationships with all of those host organizations, especially where we did the early interns up at the Buck, and where several of our interns are now employees. So the relationship building aspect of this has gone very well. But we're also using this to get our message out to other kinds of associated organizations. TEDMed, for instance, has a program called Lab TV. They have a mission of encouraging women and minorities to get into the life sciences. So we created a set of intern videos that we'll use for our own outreach, and we'll also be submitting to Lab TV. This one is a little bit longer, but we just got them in last week. We were really delighted with them. So if it's all right with you guys, I'd love to play one of the good ones for you and embarrass Allie Crampton a little bit.
I started skating when I was 16 in high school. It was like a for fun thing. And I really love it. It's what I do in the mornings before I go to school, and just for fun to help me kind of get away from like all the lab things or school things and just relax and refocus.
I'm Allie Crampton. I just graduated from UC Irvine, and I'm on my way to grad school at the University of Minnesota. The past 2 summers, I've been hosted by the mitochondria team at the SENS Research Center in Mountain View, California.
I don't know exactly what I want to do with my life, but I think that's okay. I really enjoy research. I always tell people I want to be at the bench all day, every day for the rest of my life. And so being in a research center is a really good way to get time at the bench, and it's really fun working on a project that you think is really going to affect people positively. I initially found SENS last year just online. I was looking for other internships, and I was really drawn to the types of projects that they're interested in. I was lucky enough that they brought me here to learn and to participate in their research. This year at the Research Center, there's 2 male interns and I'm the only female. Last summer though, there were 3 female interns, so I feel like I'm constantly surrounded by a lot of women, but I didn't expect that when I was starting. Particularly coming from high school and going to college, I was really nervous about being the only woman in a class or being the only one, in your group that was going to be female. And I think the advice that I would give to someone else who is at that stage of choosing, do I go to science or do I not, is if you like it, it will be okay and you will not be alone, and you should just go for it and do it, because I have so much fun and I'm really glad that I got over that anxiety and nervousness to just go for it and try it. I'm working with the mitochondria team. Mitochondria are what creates energy in your cell, basically, and they can have certain types of damage, and so our idea is to render any damage to the mitochondrial DNA moot. My project specifically is working on optimizing the system that we have implemented to accomplish this. As a summer intern, you don't, change the world, but you definitely get to make some progress towards the ultimate goal of creating this functional system to rescue mitochondria. I like the way that SENS thinks about problems, mitigating the damage before it creates a disease. There's nothing wrong with going and trying to find something out about a basic fundamental mechanism, and in a lot of ways that's what we do as well. But I feel like I'm driven to work harder and to push harder when I believe that there's something at the end of the line that would really be patient implemented. And so that's what I like about the SENS stuff, is that even if it's only 10% effective, it would really make a huge positive impact. So if you were able to mitigate aging and make it so that people were able to control their bodies well enough to do intense physical exercise, then you would be able to have a 110-year-old skater. Right now it's not possible, but that's the goal. That's the ultimate goal, is to make it so that people are healthy for a very, very, very long time. If I could continue skating when I was 110, I'd love that.
You guys gotta love the way Greg takes an intern program, speaks to what they want to hear about women and minorities in life sciences, and then insidiously slips our message right in there. And kind of ends on that as well. So Allie's going to become not just a good intern, but a great ambassador for our organization in the future. And speaking of ambassadors, what you see here is the new Celebrity Reimagine Aging campaign. This is just an nascent effort right now. It's still up to us to really put it to work. It's been spearheaded by our staff member, Maria Entregues. This particular photo, that's jazz musician Herbie Hancock, and he's asking us to repair his arthritis so he can continue playing his piano. These kinds of things are a more traditional approach for nonprofits to create mainstream awareness and reach out to the general public, but in our case, it's always resulted in more than just idle statements of support. Eddie James almost ended up attending several events for us, and as you saw, he's going to be doing the voiceover for all the animations that we're doing. Herbie has attended some special events. So far that's been without his piano, but we're working on that as well. We're going to get the SENS Research benefit concert going, I hope. And Dan's been here the whole conference, except for my talk, I guess. So thank you, Dan. And we have this conference, of course, which is no small shakes for building credibility. But let's go back to this broken bridge for a second. I hope we can say we're doing our part on the credibility side. I just want to talk a little bit about a couple of ideas regarding the paradigm issue. The paradigm for treating aging right now is to treat disease. And what we want to do is treat damage. Treating disease means you have to wait until there's something wrong. You have to wait until you're sick before we can treat you. And it means any treatment to be approved usually needs to demonstrate a one-to-one correspondence in correcting the pathology. It's a sort of a perversion of the first do no harm part of the Hippocratic Oath, where right now, with our chronic disease burden, we're often waiting until it's too late to really do anything before we try to do anything about the problem. You remember these two flagship programs I was talking about. We'll go back to what I was talking about as being important about these applications. They're treatments that will be labeled for a disease, but they will apply to early damage rather than late-stage disease by design. In one case, macular degeneration, and the other, athero. And that'll be an introductory paradigm for pushing these kinds of technologies into the market and making the market understand that these are really cost-effective and efficient drugs and interventions. And that's fine as a starter. It's fine where one kind of damage will relate to one kind of disease and will fix it. And serendipitously, we have a couple of those programs going. The problem is, let me bring this slide up again, most of these diseases of age don't really eventually operate on just a one-to-one basis. Many kinds of damage have to be corrected before you might see progress in the prevention of any specific disease. And to label an intervention for prevention of disease, the best analogy right now is the vaccine. And the do no harm threshold there is dauntingly high. The Flumist intranasal flu vaccine that I worked on was in tens of thousands of patients, and that was over 3 decades before it got approval. And if your message, James, is we can't wait, that ain't gonna work. Eli Lilly's trials for Alzheimer's drugs might be an example here. They had phase 3 trials that removed amyloid plaque but didn't stop the disease, didn't meet their clinical endpoints. Maybe there were damage factors that were not remitted. Maybe neurofibrillary tangles needed to be removed. Maybe cell therapy needed to be done. I'm not the expert on the science in this, but the bottom line message I want to give you is that there may be a drug that might be very effective in reducing or repairing a type of damage that may never see the market. I know they're re-enrolling now, but there's no guarantee that this ever gets out. But I want to leave you with an idea to play with. This is just an idea, a suggestion that the business model for drugs like that could start to change in our direction a little bit. Steve Burrell is of Burrell & Company. It's an investment company in the Bay Area. It's substantial life sciences involvement. He presented some interesting observations, which I'm putting up on the board here last week. It's focused mostly on the emergence of large new healthcare markets and on the emergence of new tech and data technologies. These bullets are all straight from his slides with his permission, by the way. The upshot of his presentation is that there are two big changes coming our way. The first change is that there are countries, especially developing world countries, that are developing sophisticated healthcare systems for their populations, but they're doing it for the first time, and in some cases almost from scratch. And for some reason, they aren't considering the US model of gargantuan costs and lukewarm results to be their definition of the model system. They're more interested in paying for overall results than in paying for services and drugs, and interventions one at a time, like we do in the US and for the most part here. If you're interested in this, pick up William Hazeltine's book. It's called Affordable Excellence, and it's about Singapore and the emergence of their healthcare system there. The second change is that we're entering an age of empowered consumers. Medical customers will soon have access, as George noted, for the genome, to their whole genomes for a few bucks. Steve says we're going to have cell phones you can hold up to your heart and get an EKG readout. Once you're able to do that, I'm sure the next day there's going to be 20 apps for $1 a piece that is going to give you a full interpretation of exactly what that readout means. These consumers are not going to be reliant on doctors' diagnoses and procedures. They're going to be much more self-reliant. They don't want tests. They want correct diagnoses. They don't want medical procedures. They don't want drugs. They want medical outcomes. They want drug results. This could represent a move from a process-based model to a results-based model in the entire medical system. Less about paying for procedures and processes, more about paying for the outcome. There's some evidence that this attitude may already be spilling over into the US, where changes in healthcare are enormously hard, as anybody who watches a political news show knows. But the Affordable Care Act actually has created some new incentives for cost control. It's created a new thing called accountable care organizations, which have to be responsible for certain outcomes. It's bundled some payments for outcomes. It's created an institute for outcomes research. So okay, that's fine for controlling hospital bills. And if any of you read about that $900 bottle of saline solution IV that got criticized a few weeks ago, might stop that from happening. But in the developed world, we're going to protect the market for drugs, right? I mean, that's our bread and butter in the big pharma industry. We'd never do risk sharing to risk the threat of profits to drug interventions for chronic disease, right? I mean, that would be impossible, right? Well, in fact, we're already doing it. This is a list from Ernst & Young, a brief list of risk-sharing agreements that right now provide reimbursements for drugs based on efficacy or refuse payment for non-efficacy. And this is all Europe and US. This is all developed world. And this looks like it might be a harbinger of the future of medical markets. And this might be, I'll try to leave this up for a minute, but I'm running very tight on time, so I won't go through the deals. But this could be real news for our foundation. We, SRF that is, we're promoting a general move toward the treatment of pre-disease damage. Quite loosely, call it the vaccination approach to age-related disease. The interventions we promote will be designed to prevent the initiation of age-related disease and keep the patient from becoming a patient. In theory, that should feed wonderfully into an outcomes-based model for management of chronic disease. Because right now you don't have any real other options. Now, it'll definitely have to be mixed with a much, much better understanding of all the damage biomarkers of age-related disease and what we can possibly do about them. Lilly's drug, if it doesn't cure Alzheimer's now, still won't by itself. But that's exactly the kind of inquiry we're trying to promote at the foundation. If we could discover which set of interventions additively would prevent Alzheimer's completely, we could transform the outcomes model. Right now, it's easy to imagine improved diagnostic tools with these great data technologies coming in. It's easy to imagine improved lifestyle management tools like using a Fitbit, which a lot of people I see here have one on right now, I'm sure. But if we're really going to forestall age-related disease, we're going to have to move to an outcomes model on a more wholesale basis. We're going to have to move to one that includes interventions that are comprehensive enough to fully prevent the diseases. And frankly, we think that is only a SENS model. Okay, so it's possible the outcomes model could be good for SENS, and if we've done our part, and if we build all the credibility that I talked about, we can get some good preclinical results from the A2E and the 7KC JOC program. And if the medical markets really do move this way, well, maybe with a little luck, we can transform medicine. So for my acknowledgements, I just want to thank all our staff at SENS Research Foundation, but especially Ben, Lisa, Greg, Maria, Gary, Daniel, and Tanya, because there is a lot more behind the scenes work going on at this conference than you probably realize to keep it all smooth. And also all the work by Methuselah Foundation and Aubrey before we existed, and all of you for attending. And if I could, just get everybody from the foundation and maybe the extramural sponsorees to just stand for a second so we could just say hi.